Okay, welcome, Dr. Kassavin. Thank you so much for joining us it's a very important topic that you have, and it is so complicated. So you have the floor, and thank you so much.
Thank you so much. It's terrific to be able to talk about this important problem, and I look forward to answering whatever questions that anyone may have and giving a good overview of the common vascular conditions that patients may have and their management. So as a brief introduction, again, my name is Dr. Daniel Kassavin. I'm a vascular surgeon. I'm based out of Cambridge Hospital, Everett Hospital, and I also see patients at Somerville Surgical Clinic. I'm board certified in vascular surgery. I have no conflicts of interest. And if anyone has any additional questions or you want to read up a little bit more, I highly suggest going to vascular.org, which is the official website of the Society of Vascular Surgery, where they have quite a bit of additional information for patients who may have additional questions. And so, as a brief overview, your vascular system is composed of two parts. You've got your arteries and your veins, and these function very much like a highway, if you think about it. So the arteries are what you see in red, and they carry blood away from the heart to all your different organs. This blood is oxygenated and it's rich in nutrients, and it's bringing that blood flow to your extremities and to your organs, such as your liver, your bowel, your heart, your brain. The veins do the opposite. They take away the blood, and you can see them in blue, and they take that blood away from your legs or your arms, and they return it back to the heart, where the heart could then take that blood and send it to the lungs, and that oxygen could be brought back in and the carbon dioxide be pumped out. And when we are talking about vascular disease, patients may have vascular disease in either one of these two systems. And so by modifying our risk factors, we may reduce, number one, developing these disease processes, and also, if we do already have vascular disease, to minimize the risk of progression. And when it's needed, we obviously have many interventions that are available to treat these problems. And so to simplify this presentation for everyone, it's going to be divided again into the arterial system, which you'll see a red square up in the top right corner and a blue square for the venous system. So the arterial disease includes peripheral arterial disease. It includes abdominal aortic disease. It includes disease of the carotid arteries, which are the blood vessels that provide blood flow to the brain. Venous disease, we'll be talking about varicose veins and about deep venous thrombosis. And so, starting off with peripheral arterial disease, peripheral arteries essentially are all the blood vessels that supply the extremities, your arms, your legs, and all the organs. And so what happens is, as our bodies age, we're exposing our bodies to various risk factors. And I'll be going into the risk factors in the following slides. And as a result of these risk factors, we could develop plaque. And this is called atherosclerosis. And the plaque is a composition of many different components. There's a fatty component to plaque. It could be rich in cholesterol, inflammatory cells, fibrous type tissue. And so what happens as that narrowing progresses, you go from having an open blood vessels, which you could see in the top left-hand corner, to something that's progressively getting narrowed. And ultimately what can happen is a blood vessel could completely occlude or get blocked, or in some cases the plaque could rupture, which could as well result in complete blockage. And so what are the risk factors? Well, tobacco use is a major risk factor. Obviously at some point tobacco was being widely advertised. Now we know that tobacco causes considerable harm, and we strongly encourage all our patients to not smoke. If you're diabetic, it's very important to maintain good glucose control. And we'll be going over the risk factor modifications in following slides. Other risk factors could include high cholesterol, high blood pressure, and having kidney disease. Age is also a risk factor. When we have these risks combined, unfortunately, the result is not an additive effect, but a multiplicative effect. And so the patients who are at highest risk of limb loss are diabetics who smoke. And so this in particular is a very bad combination. And, if you find yourself, unfortunately, as a diabetic, you want to do everything possible to keep your sugars under good control, but also not smoke, because combining diabetes and smoking, these folks are at the highest risk of limb loss. So how do patients with peripheral arterial disease present? A lot of patients may have some underlying disease and may simply be asymptomatic because they're not stressing their muscles enough to the point where they're not getting that required blood flow. In some other patients, you may have some pain or cramping or aching with walking. And typically that will either involve the calves or the thighs. And the type of pain is like an ache. And it's a very consistent and reproducible type of pain with a set distance of walking. So patients may present, to my office and say, after I walk 2 blocks, I have to stop and rest. And it's very consistent. 2 blocks, it always happens. That's very consistent with peripheral arterial disease and this condition, which is called claudication, arterial claudication, where because of the blockages, you're just not, the muscle, when it needs it most, is not getting that blood supply during exercise. In patients with more advanced forms of peripheral arterial disease, they may present with pain in the foot or the extremity, maybe cold, numb, or tingling. And in the most severe forms, patients will have chronic non-healing wounds. And the way that we diagnose patients is with clinical exam or a screening test. And so on the right-hand side, you see a little schematic of what this plaque potentially looks like. And as the disease progresses, this will typically be found on multiple levels. And so that's why it's just so important to get those risk factors under control. So what is the overall significance of peripheral arterial disease? Why will this affect, a patient day to day? Well, in milder forms, it's going to affect someone's quality of life because when that patient walks, they're just not going to get enough circulation to the extremity. And they may develop some discomfort in the calf or other parts of the legs. In more severe forms, there may be a risk of limb loss, especially if there's an active ulcer present. It's also significant because that same disease that someone may have in the leg, it will not be isolated just to the leg. Those same risk factors affect all the blood vessels in the body, whether they be the carotids in the neck, the coronary arteries that provide blood flow to the heart, or to the other arteries in the body. And as a result, folks with peripheral arterial disease will have a higher risk of heart attack and or stroke. And folks with more severe forms of peripheral arterial disease, the 10-year risk of death can be as high as 40%. And mostly it's from heart attack and stroke. So what are some of the things that we could do to lower our risk of PAD, getting PAD, and lower the risk of progression? Well, number one, we want to stop smoking. That also includes avoiding secondhand exposure as well. If we're diabetic, we want to get our sugars under control. If we have abnormal cholesterol, we want to work on that, and that could be done through increased physical exercise. That could include changing your diet, and that could include addition of certain medications such as statins. If our blood pressure is not well controlled, we want to address that, whether it be with dietary changes, salt restriction, and or medication. Exercise and weight loss is very important. Proper diet, which we mentioned. And there's some medications which have been found to be beneficial in patients with peripheral arterial disease. That could include antiplatelet agents such as aspirin. Obviously, you always want to weigh the benefits versus the risks. So patients with peripheral arterial disease have a benefit with aspirin. Obviously, if someone has a history of bleeding, let's say gastric ulcers, that should be addressed to minimize that risk. Other medications which may be beneficial include statins, which is an anti-cholesterol medication, and the use of silastazole, which is a medication which we prescribe patients with claudication, which is that pain that patients may develop in the leg when they walk. Moving on to the options. So let's say we've exhausted medical management, or a patient presents with very severe disease. Well, then we need to start talking about revascularization options. And that basically means, what are we going to do to reintroduce blood flow to those end organs, whether it be the extremities or other parts of the body. The indications to do this, again, is typically with more severe forms of disease, whether it be a non-healing ulcer, breast pain, or if a patient has a very severe debilitating claudication complaints. Again, that's the pain that someone may have in the calves or the thighs when they're walking. And the options include balloon angioplasty, which is what you see here on the top left-hand side. That's a balloon being inflated inside of a narrowing. In some cases, we could put a stent, and in some cases, we could do what's called a bypass, in which case you skip that area of disease and you connect healthy artery to healthy artery and essentially bypass that area. So I'm going to move on to abdominal aortic aneurysms, which also falls within the arterial system. So the aorta is the main artery of the body. And so from the heart, that goes down the chest and into the abdomen and around the level of the belly button, it splits into two, with each branch going down each leg. And so an aneurysm is when you have weakening of the wall of an artery, and as a result of the weakening of the wall, that artery dilates. And instead of being a normal diameter of anywhere from 15 to 20 millimeters, just under an inch, the artery can the aorta can dilate up to 2, 3 inches or greater than that. And as a result of that, there's a concern and a risk of rupture. And rupture results in essentially death, because that causes massive blood loss inside the body. And so what we want to do in patients with this process is to catch it early and to treat it early. And that way you prevent that rupture from taking place. And so we typically will screen patients who have risk factors and try to catch this early. And I'll be going over what those risk factors entail. And those risk factors include patients who are greater than the age of 60, who have a family history of aneurysms, who have smoked. COPD is a risk factor for progression of these aneurysms, and men appear to be at higher risk of aneurysms in women. And once an aneurysm has been detected, it should be monitored at set intervals to make sure that it is not expanding too fast, and to make sure it hasn't reached our threshold for repair, which in most patients is going to be anywhere from 5 to 5.5 centimeters. When that threshold has been reached, we start to discuss options for repair. And the two options are either an open approach, whereby an open incision is made in the abdomen and healthy artery is connected to healthy artery, thereby excluding that aneurysm and depressurizing it and eliminating that risk for rupture. Or we could also use what's known as a stent graft, which you can see in the bottom right-hand corner, which basically connects a healthy segment of the aorta to a healthy artery distally down below that aneurysm. And by doing that, you're excluding this aneurysmal component and removing that pressurization and eliminating a cause of rupture. So who do we screen? We screen men or women who are greater than 65 years of age and who have the risk factors. Those risk factors include a history of smoking, a family history of aneurysms, and if you've got other aneurysms in other parts of the body, there is a higher risk of having abdominal aortic aneurysm as well. This is going to be the final part of the talk for the arterial component, and this is the carotid artery disease slides. And so this is due to the buildup of plaque in the carotid arteries, which are the main, some of them, a pair of the main blood vessels that supply the front of the brain. And so when we have narrowing in these blood vessels, there's a risk of plaque breaking off and potentially migrating to the brain, which essentially results in a stroke. And this could be due to either the plaque rupture or due to migration of some blood aggregates of blood products. And stroke could be very debilitating. It's the 5th leading cause of death in the United States. And we want to be able to catch the risk factors early and prevent stroke from taking place. What are the risk factors for carotid artery disease? They're very similar to the other risk factors for peripheral arterial disease and aneurysmal disease. And this includes tobacco use, diabetes, obesity, having high cholesterol, having high blood pressure, increased age, and a lack of exercise. So what symptoms will patients have who have got carotid artery disease? Most patients will not have any symptoms. However, in the patients who do have symptoms, a stroke can be the first sign. This is when someone presents with sudden neurological deficit, such as a loss of motor functioning in an arm or an extremity or a lower extremity, or changes in sensation, or changes in a visual disturbance, such as a curtain falling over the eye, or a speech deficit. Sometimes patients may have a mini stroke, which is essentially when the symptoms last for a few minutes to hours. The symptoms are essentially similar, however, resolved shortly thereafter. Regardless of whether or not this is a stroke or a mini stroke, this is essentially an emergency. And should anyone you know have this, they need to be evaluated urgently in an emergency department. So this is a nice mnemonic that we have. If you're concerned or suspect a stroke, remember the FAST acronym. And so F stands for face. It's when there's asymmetry within the face, someone's not able to bring up the corner of their lip, or if there's a droopy eyelid. Arms, if the arm has gone flaccid, they're not able to move their arm, or if there's a change in sensation. Speech is a potential area that could be affected. Is the speech slurred? Is there a problem with comprehension or with enunciating words? And that could be a sign of stroke. And if any or any combination of these symptoms are present, time is of the essence, and you need to call 911 essentially emergently. So who do we screen for this disease process? Patients who are greater than 65 years of age and have a history of coronary artery disease, those who have smoked, have an elevated cholesterol level, or have peripheral arterial disease. And the mainstay of surgery, mainstay of surgical treatment is what you see over here. This is called a carotid endarterectomy, where an incision is made to expose a blood vessel, and this blood vessel is opened up and the plaque is physically removed, and that blood vessel is subsequently closed up again. I'm going to be moving on to the venous segment. You should probably, I'll keep the questions till the end of the presentation. Is that okay? Okay, super. So the two conditions that we'll be discussing in the venous disease section will be consisting of varicose veins, which is where the superficial veins are affected. These are the veins that are in your subcutaneous tissue, which is basically that tissue that's right and directly underneath your skin. And in patients who do have varicose veins, often they'll be directly right under the skin, and there'll be these very large, very easily noticeable vessels. And these can be surgically removed if needed, or addressed with other interventions. Then we've got deep venous thrombosis, and this differs in that these are veins that are within the deep muscular compartments, usually paired with the arteries, and these need to be, should there be a problem in that system, they need to be addressed in a completely different way, as they cannot be removed. They are irreplaceable. So moving on with varicose veins. Varicose veins are dark, bulging, and painful veins that are very close to the skin. In mild forms, varicose veins will result in aching, cramping, ankles, feeling heavy. And that's what you see on the left-hand side here. This is the backside of someone's calves. You can see these very superficial varicosities. They're protuberant, and you can see some additional lesser forms of varicose veins, which are known as spider veins and reticular veins. Just to the right of that, you can see a fairly large varicose vein. And in some patients, they may have progression where instead of just simply having varicose veins, they may develop some swelling in the ankle. They may develop chronic stasis changes of the skin, where the skin loses some of its integrity instead of it being soft and supple due to the leakage of blood breakdown products into the surrounding tissue. They may develop this hardening and fibrotic changes. And this becomes relevant because not only does it result in symptoms of associated discomfort, but if that area is damaged, let's say someone scratches it, this area is more prone to develop an ulcer, and that ulcer in turn is less likely to heal, and it's going to take additional care for it to heal. And that's what you can see in the rightmost screenshot is a chronic venous ulceration. So what is it about varicose veins that they lose their functioning? Well, it's as a result of loss of valvular function. So on the left-hand side, you can see what a normal vein looks like. Veins have valves within them. So this ensures unidirectional blood flow. So when the blood goes up, it stays up. These valves capture that blood and prevent that refluxing back down the leg. However, in patients who have varicose veins, these valves lose their functional ability. They no longer come together and the vein dilates. And what happens is that instead of having that unidirectional blood flow, it will go up and then come back down. It's like 2 steps forward, but then 2 steps back. And as a result of that, this blood will then stagnate in these vessels, and you'll have swelling of these vessels, which in turn causes symptoms, but also the leakage of the blood breakdown products into the surrounding tissue will cause that chronic scarring and discoloration that you saw with these patients over here. So what are the risk factors for varicose vein disease? Well, pregnancies is a risk factor, and it's thought that's a result of the increased pressure of the gravity uterus on the pelvis, as well as exposure to these changes in hormonal changes. A family history is a risk factor. Typically, it's very common to have a family member, whether it be a mother, father, or grandparent, for you to have varicose veins as well. There's certain occupations that increase risk of varicose veins, those that involve a lot of standing. So nurses, waitresses, other occupations that involve standing will have an increased risk of varicose veins, and it's a good idea to wear compression stockings. As we get older, there's an increased risk of varicose veins, being obese, and having a prior history of deep vein thrombosis. How do we medically manage varicose vein disease? Well, compression stockings are a mainstay. These could be obtained either over the counter, or if you see a health professional, you can be prescribed stronger compression stockings. When you're resting, you want to elevate your legs. You want to address any weight issues. So if you're obese, you want to work on losing some weight. Exercise is important because our calves are the muscles which envelop the veins, act as a natural calf pump. And when you exercise, those muscles will squeeze the vein and help return that blood flow back. In some patients, over-the-counter medication called horse chestnut extract or deosmin has been shown to alleviate some of the inflammatory changes you can have with veins. And you want to protect the skin integrity. So you want to apply moisturizer to the skin and prevent yourself from scratching that skin and potentially forming a wound. What are some of the options for treatment? Really depends what you present with. And so the 3 most common options are an ablation, and that could involve the use either of a laser or radio frequency catheter, which basically closes that non-functioning vein down. And by closing that vein that doesn't function, you're redirecting blood flow into veins that work properly. For other veins that are very superficial, we can make small incisions and pull out the veins. And in other patients, sclerotherapy is an option, which involves injecting these very small veins with a solution that causes them to shut down. When patients present with more severe forms of varicose vein disease, wherein there are venous ulcerations in the leg, mainstay of treatment includes the use of an Unibut, which is a multi-layer compression dressing, and allows those varicose veins that are incompetent to be collapsed and redirect the blood flow into veins that function properly. Patients are also evaluated for closure of the veins that have the insufficiency, and here you could see a catheter being used to shut down that vein, and there's other options as well. We're moving on to the final topic, and that's the deep vein thrombosis. And thrombosis is essentially a blood clot. And so this is a blood clot that occurs in the deep veins, which are those veins that are deeper in the body, typically within muscle compartments associated with your arteries. And when a deep vein thrombosis forms, there's a risk of it breaking off and potentially traveling to the lungs, and that's called a pulmonary embolism, which in turn could be a very severe complication, and in some cases it could be, in many cases it could be life-threatening. So what are some of the symptoms that we could have in an acute setting with deep vein thrombosis? Our leg would feel pain, there'd be swelling, there'd be warmth. This could also include the upper extremity as well. With pulmonary embolism, symptoms will typically include shortness of breath with exertion, even sometimes at rest. You may have also chest pain. What are the risk factors for forming a DVT? Having recent surgery, an injury, or period of immobility, having a cast on the leg has been sometimes associated with deep vein thrombosis. History of cancer, receiving chemotherapy, patients with a prior history of deep vein thrombosis, a family history of DVT, patients who have a propensity due to a mutation in blood clotting factors can result in a deep vein thrombosis, inflammatory bowel disease, certain oral contraceptives, pregnancy, and age. So you can see here, we're looking out the airplane window, and so that is associated, you're in an airplane and you're not moving and you're in your chair for an 8-hour period. This could sometimes contribute to a deep vein thrombosis, which is why it's important, even if you're sitting, to try to move your legs, to try to get up and walk down the aisle. So how do you lower your risk of deep vein thrombosis? Well, you want to stay well hydrated. You want to maintain activity levels, avoid prolonged periods of immobility, whether that include car trips, taking stops, or if you're in an airplane, getting up and trying to get the blood moving in your legs. You want to wear compression stockings. And you want to, if you have a concern about blood clotting disorders in your family, well, then you want to potentially discuss the appropriateness of a blood thinner with a medical doctor or health provider. If somebody's been diagnosed with deep vein thrombosis, the mainstay of treatment is blood thinner. This is essential because if someone is not on a blood thinner, there's that risk of that clot extending and potentially getting larger, affecting more of the extremity and of potentially going to the lungs, which again, as we mentioned, could be a lethal event. And we do have procedures to remove the clot in the acute setting. For chronic conditions, we typically will prescribe compression stockings. We strongly encourage leg elevation, weight loss, and where needed, we have interventions as well that are available. And so that concludes the presentation. I see patients at Everett Hospital, Cambridge Hospital, as well as Somerville Hospital. This is the phone number for the call center, where if you need an appointment, I'm happy to see any patients. And if anyone has any questions, please, I'm happy to take them at this point.
So thank you for that incredibly detailed and informational presentation. There is so much to this. There was not one question in the chat, but I had a couple of comments and I wanted to run by you. And actually, I jotted down a few questions, but you were so thorough, you answered them along the way. So that maybe that's the case with other folks as well. So it seems we need to keep the blood flowing. That's the long and the short of it, keep the blood flowing. And the risk factors, are pretty much the same risk factors of any disease. Diet, pay attention to our diet, keep moving, and, hydrate. Now, the other thing I wanted to point out was, age is a risk factor in a lot of these things, but just because we're getting older, that doesn't mean that we're going to get these things, right? If we can stay on the other side and keep moving and watch our diet and stop smoking and do all the things to help ourselves, then we have a better chance of not getting these things, correct?
Absolutely, yes. it's all about modifying your risk factors. Just like you mentioned, if we're diabetic, we want to make sure our sugar's under control. Aim for that hemoglobin A1C of less than 6 or lower. Keep our blood pressure under control. Exercise. A number of patients may develop some form of PAD, but by addressing your risk factors, you could prevent that from progressing. And in many cases, you're noticing you're having limitations in your ambulation. You're not able to walk as much as you could before. Often by engaging in those risk factor modification and developing a regular walking regimen, you can improve your symptoms. So that's actually the first mainstay of therapy, is for patients who do present with issues with circulation to the legs as a result of narrowing. We prescribe a walking regimen. So you want to develop a regular walking program where for at least five times a week, preferably for 30-minute durations, patients walk. And they may not be able to walk for 30-minute straight durations, but it's essential to walk as far as you can until that discomfort in the calves prevents you from walking further. You stop, you rest, the pain goes away, and you start walking again. And if you maintain a regular regimental program like that, patients will see significant improvements in their walking distances. And they'll as well have the benefits of reducing probably other cardiovascular complications, such as risk of heart attack and stroke.
Any movement is better than none. Is that correct?
Absolutely, absolutely, absolutely.
The other thing, you mentioned it. I do a lot of herbals, but I've never heard of this horse chestnut extract.
So yeah, so this is specifically for varicose veins. So patients with varicose veins, they may benefit from horse chestnut extract, or diosmin is an alternate. And so these compounds have something called flavonoids, and it's been shown to be beneficial and reduce the symptoms that patients could have associated with their varicose veins.
But they shouldn't add this unless they check with their doctor. Is that correct? Or does it matter?
I think it's not unreasonable. You could certainly try.
Okay.
But I mean, if you're taking a lot of other medications and you've got a concern about interaction, I think it's always a good idea to check with your primary care doc.
And I guess the last point I want to make is you are a vascular surgeon, and to get to you, is it a referral from a primary care provider? Typically,
sometimes I do see patients who just come directly to see me. So if you've got varicose veins and they're bothering you, I'm happy to assess them. Same thing with some of the other conditions, because sometimes patients know that either they've got risk factors or they've been diagnosed with some of these conditions in the past, whether it be peripheral arterial disease or carotid stenosis or aneurysms, and they're being monitored. I'm happy to continue monitoring these conditions as well.
Great, thank you so much. So I just want to let the folks know that, as we said before, this presentation is recorded and will be put up on the Cambridge Health Alliance Older Adult page, because there is so much information here that I'm sure we couldn't process it all at once. So it's good to be able to refer back to it. So thank you so much, Dr. Kassavin, for your time.
Thank you. Thank you.
Thank you, everyone. And we'll see you next month when we talk to Dr. Michael Theodolou about all of the new procedures for feet and how important they are. We know that, right? All right. Thank you so much. We'll see you next month.
Take care. Thank you.
Stay safe. Stay well. Thank you, Dr. Kassavin.